Another technique you will use, and this one quite frequently, is going to be the Bitewing technique. And with this technique, the x-rays are taken so that the image can be used to examine the interproximal surfaces of the teeth, so the space in between. On one film, you will see the crowns of the maxillary and mandibular teeth, all on one film. You will be able to see closely the interproximal areas, which is why this type of film is often used to detect caries or decay. And the bitewing is often used to examine the crestal bone level, which is in between teeth. The finer details that you will find on a bitewing include the alveolar bone. This is the bone that encases and supports the root of the teeth. And you will also find crestal bone, which is the coronal portion or the crown, closest to the crown, part of the alveolar bone found in between the teeth. So here we have an example of the alveolar bone. You can see that tooth sits down into that bone and surrounds the entire root of the tooth. And then the crestal bone, the area where there are these little arrows pointing right here. This is the crestal bone, the highest portion. That crestal bone level can change over time, and that's one of the things that the bitewing may be used to view is if that crestal bone level has changed and how much it has changed, if it has. Also with a bitewing, we have something that may be called an open contact. This is a thin radiolucent line between adjacent teeth, or basically it has captured the space in between the teeth. Or an overlapped contact, which is when a contact area is superimposed over the contact area of adjacent teeth. So basically you'll see kind of a white area, a lightened area, or little radiopaque area on the adjacent tooth. And here is an open contact. And you can see here this radiolucent line or this radiolucent space. Here's a little bit larger one. But all of these areas where you can see these radiolucencies, these are considered open contacts. And that is actually ideal for any radiograph is to have those open contacts. And then you can see in this picture, we have the overlapped contact. So how you can see the outline of the other tooth superimposed across the adjacent tooth. So here we have an overlap, here we have an overlap, and then on the maxillary there's an overlap here, and then there's an overlap here. So that would almost or could almost be considered a non-diagnostic x-ray just because the amount of overlap that is there. Principles of the bitewing technique, and they can be described as follows. First thing you're going to do, the receptor will be placed in the mouth parallel to the crowns of the teeth. So remember, parallel is when you have two lines or two items running in the same direction with the equal distance between the two things for the entire duration. The receptor is then stabilized when the patient bites on the film holder. The central ray is directed through the contacts. Directly through the contact is going to give us the open contact. And we want to use a vertical angulation of plus 10 degrees. So this is where you can take the tube head and move it up and down. Think of it as nodding your head yes. Incorrect angulation will create a level of distortion. It will make the images appear not like what they're supposed to appear and will again render the image undiagnostic. With this technique, we also have a beam alignment device or a film holder, and this is going to position the receptor and maintain position in the mouth. So it's going to help keep it where it's supposed to be. And XCP is recommended for this technique as well. You can also use something called a Bitewing tab. And this was the original Bitewing technique. It just used the tab. Before they were able to have XCP for this technique, they just used this little tab. And what this tab is just an adhesive tab made of plastic. Okay, I'm going to stop there. I'm going to have to start the slide over because we have the word heave here. The Bitewing technique also requires or recommends a beam alignment device. This is the film holder. And what it is going to do is position the receptor and maintain position in the mouth. So it's the stabilizer. It's going to help prevent any movement or do as much as possible to prevent any movement. So XCP is recommended. So XCP is recommended similar to the paralleling technique. But there is also another method that can be used, and that is the Bitewing tab. This was the original Bitewing technique. Before XCP was available, they had these adhesive tabs made of plastic or heavy paperboard that attached to the receptor. So it was just kind of like little sticky back paper that you could fold in half and stick onto the film and place it in the patient's mouth, and they bit on the little tab. And it was less bulky in the patient's mouth, but sometimes because you didn't have the aiming ring to aim at the patient's mouth, sometimes this technique caused a lot of errors, so it wasn't always the best when learning. Once you used it and once you became very adapted to using that technique, it would just be very simple to you and it would be like second nature. These also come in various sizes and can be used on a horizontal or a vertical bite wing. For the receptors or your film or your sensor. Again, there's going to be a variety of sizes available. And the first one is a size 0. This is going to be used for children with a primary dentition and always placed horizontal. Size 2 is going to be used for most bite wing exposures, especially with adults. And it can be placed in a vertical direction or the traditional horizontal direction. Size 3 bite wing film. It's used only for bite wings, and it's going to capture all posterior teeth, so all premolars and all molars, in one quadrant on a film. But it is no longer recommended because of the overlap. There's a curve in your arch between the molar and the premolar area, and that film will hardly ever sit correctly so that there is no overlap. So those contacts are never going to be open, and that is why this film is not recommended to use. Also, because it is a more narrow film, you may not see the crestal bone if the patient has a large amount of bone loss. A size 1 film is also available for bite wings, and it's going to be used mostly for posterior teeth in children that have a mixed dentition. And it's usually going to be placed in a horizontal direction. But it can also be used in the anterior if a vertical bite wing is going to be taken in the anterior. PID angulation is going to be very important when it comes to taking your bite wings. And the first angulation we want to talk about is horizontal, or this is side to side. So think of it as shaking your head no. You want to make sure that the central ray is perpendicular to the curve of the arch and through the contact areas. So this goes back to open contact. If it is perpendicular to the curve of the arch and it goes through the contact area, you will have those open contacts. If you do not have it perpendicular, you will have incorrect angulation, which will cause overlap in the contact areas or those radiopaque superimpositions on the adjacent teeth. And this will make it more difficult to detect caries and could lead to problems for your patient as the cavity will grow. Vertical angulation is your up and down, or again, that shaking of the head up and down as if you're saying yes. And with this angulation, we do have degrees, and a positive 10 degrees is recommended for your vertical angulation. And this is where the central ray would be directed in that slightly downward angle. Some rules to remember when you are taking bite wings. First one is going to be your receptor placement, whether it's the film or the sensor. You want to make sure that it covers the prescribed area for the teeth to be examined. Too far forward, you may cut off a tooth in the back. Too far back, you may cut off a tooth in the front. Next is the receptor position. It needs to be parallel to the crowns of both the maxillary and the mandibular teeth. Starting the slide again due to the placement of that photo. So here we go, 3, 2, 1. Some rules for the bite wing technique. If you follow these rules and keep them in mind, you should get a good shot every time. And that first rule is going to be your receptor placement. You want to make sure that it covers the prescribed area of the teeth to be examined. So if you're too far forward or too far back, you may cut off one of those teeth that were prescribed to be radiographed. Next, we have the receptor position. It should be parallel to the crowns of both maxillary and mandibular teeth. This will help stabilize or will be stabilized when the patient bites on the tab or the beam alignment device or that film holder. Keep in mind with your vertical angulation, it should be at positive 10 degrees. And with your horizontal angulation, that central ray should be directly through the contacts. Take 3 on this slide. I think I got it this time. So here are some rules for the bite wing technique, and if you follow these rules, you should have a pretty diagnostic x-ray every time. And the first rule to think about is your receptor placement. Think about where you're placing it. It needs to cover the prescribed area of teeth to be examined. If it's too far forward or too far back, you may cut off one of the teeth that were prescribed to be radiographed. Also, the receptor position. It should be parallel to the crowns of both the maxillary and the mandibular teeth. It is stabilized when the patient bites on the tab or the beam alignment device or the film holder. Your vertical angulation should be at positive 10 degrees. And with your horizontal angulation, you want to make sure that central ray is passing directly through the contacts. Open contacts, not overlap. And your receptor exposure. Make sure the beam is centered on the receptor. If the beam is not centered, one of the errors that you may have is called a cone cut. And that is what this is an example of right here. This is called a cone cut, where you can see this is probably an XCP ring right here. You've cut off these few pieces of important information on this x-ray. So your exposure is a very important rule to think about. So that partial image or the cone cut is considered an error and that film would need to be retaken. For the procedure, first thing you're going to do, like always, is prepare the patient. After any barriers have been placed and the treatment is prepared, you seat the patient. Then you will place the lead apron, explain the procedure, ask them to take anything that's removable out of their mouth. You may ask any earrings or any facial piercings to be removed as well. You will make sure that the equipment is prepared. You will set the exposure settings. And then you will follow the Bitewing exposure sequence. Or this is the definite order of film placement and exposures that should be followed. And again, it's important to have established some kind of routine for how you're taking these films. This will prevent errors and also make some more efficient use of your time. If you have to think about where you're at, you're going to lose those seconds that it takes you to make that decision on, did I take that film or did I not take that film? So you will establish a routine to prevent errors. Typically, there's going to be 2 premolar bite wings and then 2 molar bite wings. Sometimes premolars get extracted when they're preparing for orthodontics. Just if there's not enough space, sometimes those premolars will go. Only 1 bite wing may be necessary if this is the situation. You will want to start by exposing the premolar bite wing first. This film is easier for the patient to tolerate and it's less likely to hit that gag reflex. And then you will begin to take the molars. And it doesn't matter usually if you start on the right or the left. Just know that it's best to take the premolars first and then move back to the molars. Your film placement is going to be important when taking the bite wing exposure. And typically you will have 4 total exposures as we had just discussed, 2 premolars and 2 molars. But any variations in the film placement, the film size, or the total number of films exposed can be sorry about that. I got caught in a yawn and I didn't realize that the pause didn't work. But I would like to start this slide over again. When you're exposing a bite wing, it's important to pay attention to your film placement or the specific area that the film is going to be positioned. And this is dictated by the teeth and the surrounding structures. The checklist we're going to go over here is specific to bite wings that have a 4 film series and uses a size 2. Any variation away from this can change how this checklist may go, and those variations can be dictated by the doctor that's prescribing or any other sources that you may read. And so for these checklists, for a premolar x-ray, you will want to make sure that the distal portion of the canine is visible. So the distal portion of the canine, it's visible. Both premolars are visible. So on the shot, I have 4 premolars here. The occlusal plane is in the middle of the receptor. So that the occlusal surfaces run right through or as close to the center of the film as possible. Okay, I'm going to pick this one up. So let me back it up here a minute. I'm going to pick it up starting with the premolar checklist. So starting with the premolar bite wing checklist, you want to make sure that the distal portion of the canine is visible. So here we have our x-ray. Here's our canine. We've got the distalmost portion of the canine. Next, we want to make sure that both premolars are visible. So I've got these premolars on the maxillary, these on the mandibular. The occlusal plane is in the middle of the receptor. So here we go along the occlusal plane. It's basically where the occlusal surfaces are and where they meet. The occlusal plane is parallel to the bottom of the receptor. So parallel, we've got, imagine if this could be a completely straight line. We've got one line here, and the bottom of the receptor runs along here. And then the vertical angulation was positive 10 degrees. So this particular film does not look like it has any other than a little what is normal distortion. And there is no cone cut on this film. And now we have our molar bite wing checklist. The front edge of the film in the middle of lower mandibular second premolar. So here we would have that second premolar, front edge of the film in the middle of the lower mandibular second premolar. So this maybe could be, if we wanted to be picky, could be a little bit more towards the mesial to get a little bit more center, but I'd say that's pretty much in the middle of the second premolar. The molars are both visible. We've got all of our molars there. The occlusal plane is in the middle of the receptor. The occlusal plane is parallel to the bottom of the receptor. Horizontal angulation is good because there are open contacts. Vertical angulation, again, there looks to be minimal distortion. So vertical of plus 10 degrees looks good. And that there are no cone cuts. Another part of the bite wing technique is going to be a vertical bite wing. And this is used to examine the alveolar bone and caries. Another part of the bite wing technique is going to be the vertical bite wing. This is going to be used to examine the level of alveolar bone and caries detection. Like our other techniques, we may need to have some modifications when using the bite wing technique, and this is due to the various anatomical conditions that can be present in the mouth. One of those modifications may be required due to space or edentulous areas where teeth are no longer present. To modify for this, you can place a cotton roll in the area where there are missing teeth, and this will support the bite wing tab or the film holder. So when the patient closes their mouth, the opposing teeth are so when the patient closes their mouth, the opposing teeth are going to bite down on that cotton roll and they'll support the tab or the film holder. If that support is not given though, the film will tip, causing the occlusal plane to be tilted. So one of those rules we talked about was that occlusal plane is parallel to the edge of the receptor. If they bite down and they aren't biting correctly, or they bite off, their bite is slightly off, that cotton roll won't be supportive of that bite wing tab, which will cause that film to have that slight tip to it. And the other modification can be the bony growth or tori. And remember, with tori, we are going to place the receptor between the tori and the tongue. It should not be placed on the tori. Larger tori will cause the receptor to be pushed further away from the teeth. So then when you're using the bite tab, they're going to be biting on the very end of the bite wing tab to help stabilize that film. And it's going to make it a little bit more difficult for the radiographer to figure out where the film placement is. So if this is the situation, a film holder or an XCP will be recommended over that bite wing. Over the bite wing tab. And of course, it is always important to not bend or crease the corners of the film. For review, question number 1. Which of the following describes the primary use of the bite wing radiograph? A. Examination of the apical areas of the teeth. B. Examination of the apical and interproximal areas of the teeth. C. Examination of the interproximal areas of the teeth. Or D. Examination of the pulp chamber. The correct answer is C. Examination of the interproximal areas of the teeth. Number 2. Which of the following is the correct angulation used with the bite wing technique? A. Minus 10 degrees. B. Plus 10 degrees. C. Minus 20 degrees. Or D. Plus 25 degrees. The correct answer, B. Plus 10 degrees. What size film is recommended for use with the bite wing technique in an adult patient? A. Size 1. B. Size 2. C. Size 3. D. Size 4. The correct answer is B. Size 2 for an adult patient. And the last one, what size film can be used to include all posterior teeth in one bite wing exposure? A size 1, B size 2, C size 3, or D size 4? The correct answer is C size 3, but remember this size film is no longer recommended.